Hello, this is your brain on drugs, and this is the punk rock psychiatrist. Thanks for joining me again today. And I'm continuing on with um, the antidepressants, and I'm going to take a, a little bit of a detour, and we're going to talk about a lot of the side effects. And the SSRIs is the next meds that we're going to talk about, but I think there's a lot of stuff that you need to know about these medications. These are our most prescribed meds. They're the ones that you're going to um, be most likely to be starting patients on. They're the ones primary care is using. They're if you look at the lists of the top medications that are prescribed in the United States or probably most other countries, there's several of these meds that are at the top of the list. So I think it behooves us to really dig deep into all the ins and outs of these meds. And so the first topic that I wanted to go into was on QTc prolongation. And I'm kind of jumping into that because of the warning on citalopram. And it actually exists for all of the serotonergic medications and most of the antipsychotics as well. So I thought, and we already covered the tricyclics, but actually the tricyclics as well. And so I think having a nice discussion about QTc prolongation is a good place for us to this is a good place for us to do that. And I I have to preface this, I'm not a cardiologist. I'm not an expert on QTc. I'm not an expert at reading EKGs. And so you may be thinking, well, then why am I listening to this guy? Well, because you're getting this information from the perspective of a psychiatrist, and I think a lot of psychiatrists out there probably aren't that comfortable with this topic, and I don't want to go into super deep details to the point where like I'm losing you, but I wanted to go in an overview of the topic and kind of what it has to do with us and our medications, because it is definitely out there, and I have definitely seen people go into torsades. And when I say see, I mean I didn't physically lay my eyes on it, and I wasn't the one that prescribed them the meds, but it happened in the hospital I was working in, and I heard about it, and I rounded on a patient after it happened. So it's something that can happen, and so it's something we definitely need to be aware of. And so let's get into it. So QTc prolongation, what even is this, right? And if you're a patient, I'm doing this podcast not just for the docs out there and not just for the students, but also for the patients. And so when I explain things in like super detail and make it like for dummies, not that you're anyone's a dummy, but this is like QTc for dummies, because to be honest, I'm a dummy when it comes to QTc. I was never comfortable reading these EKGs. And it's something that I've had to educate myself on a little bit more. So, um, what what this is it's a measure of the electrical signals that are going through your heart. Okay, and so when you get hooked up and you have all those little stickers on your chest and things, and we have these waves on there, and there are points in these waves that we label with letters, right? And so the P wave is the first one, and that's the depolarization and repolarization of the atria, which is the top two chambers of your heart. And then we've got the QT, the QRS. We've got the QRS, right? And that's where the ventricular depolarization and repolarization is happening. Or sorry, the depolarization. And then the T wave at the end is where repolarization of the ventricles happens. And then some people have the U wave, which is something that we don't really want to see on there. And so it's the PQRSTU. It's like, why these letters, right? I mean, I actually looked into this, and I think it was Eindhoven is his name, is the guy who kind of like mapped this all out. And They think that he was influenced by Descartes, who was a famous philosopher. I think, therefore I am, cognito ergo sum, and geometry. Descartes is French, in the 1600s. He did a lot of geometry type of stuff, and he had like a P point on a curved line or something like that, and they think that the PQRS came from. They said, well, I'll pick P, and if I pick a letter in the middle of the alphabet, if I find out that there's waves in front of P, I've got letters to play with, and I've got something after. U was discovered, and I've got some space to add that. So that's kind of where that comes from. But in psychiatry, we often think about the QT. So that's the distance from the Q point to the T point. So there's the P wave, and then you got the Q as the start of that big jump in the EKG, and then the top of it's the R, and then the S is the bottom of that, and then the T is the wave that's after that. And so the distance in between that Q point and that T point is what we're measuring. Okay. And that is the distance by which the ventricles, the bottom two stronger chambers of the heart, depolarize and repolarize. So that's where the electrical signals going through there to pump blood through the body. And we don't want the distance between that Q and the T to be too long. And that's really what this whole lecture is about. Okay. And so in males and females, the numbers are different. So for males, we want to see less than 450 milliseconds. So the distance between the Q and the T is less than 450 milliseconds. And in females, less than 460 milliseconds. All right. And so so not only do we want the number lower than that, we also don't want there to be too much of a change from the patient's baseline. So if they're 420, we don't want it jumping up to 440, even though that's still below what we want. It's a change. So a less than 10 millisecond change is a lower concern. 10 to 20 is we're having increasing concern. And then over 20 millisecond change is a definite concern. And so what could happen if we have an abnormality an increase in this distance between the Q and the T? So torsade de pointe, that's the really, really dangerous arrhythmia that people can go into. If you look at the graphic for this episode, I actually have the torsade electrical signal as my heartbeat on the graphic. So torsade, you can die from that. Like I said, I've seen 2 patients in a hospital that had it while they were in the hospital. One, they were given IV Haldol. I think both of them were given IV Haldol on top of a lot of other things that they were taking, and then that just kind of like was the straw that broke the camel's back and like threw them into torsades. So other things that you can get are ventricular ectopy, T-wave alternans, AV block, and a widened QRS. Those are not things that I'm all that familiar with, other than the torsades, but those are some other things that you can high risk features on the EKG. So let's talk about this QTc prolongation and the C. What is that little C? It's a big Q, a big T, a little C. So the C is corrected. So that there's some sort of mathematical equation that you throw this stuff through that like makes a more accurate measurement of this QT. And so we call it QTc prolongation. So that's, it's getting too long. It's, over that 450 or 60 milliseconds. And this is putting it at risk for torsade de pointe. Big T, little d, big P. It's a French word. It basically means I think torsade means twisting and point means point, like twisting on a point. And I think if you look at the way the signal looks compared to a normal EKG, you can kind of see that it looks like it's twisting on a point. And so that's where that name comes from, but it's extremely dangerous. So there's some non-modifiable risk factors for getting torsades. So congenital long QT syndrome. So there are QT syndromes that people have as like a medical condition. If you already have that, we don't want to make it worse by you taking a medication that could cause it. Being elderly. And so remember, these are non-modifiable. So these are things that, the patient just has. There's nothing we can do about it to make it this risk of these things better. So being over 65, family history of sudden cardiac death at ages less than 50, the female sex, history, if you have had a history of arrhythmias, so irregular heart rates, if you have had a myocardial infarction, heart attack, and if you have some sort of structural brain disease. I'm not exactly sure how the brain disease would cause this, but it may have something to do with the way the electrical signals are conducted down to the heart. You can also, those are the non-modifiable. What are some things that we might be able to modify? Okay. So bradycardia, so pulse less than 50, that's something we might be able to that we should be able to fix. Electrolyte disorders, so low calcium, low magnesium, low potassium, those are all things that can increase your QT, that we can correct those. Eating disorders, very hard to modify, but modifiable. Um, Heart failure, low blood sugar, high blood pressure, low thyroid hormone, um, drugs interactions that increase the levels of other meds that increase your QT. So, you're taking a med that can increase your QT, and then you've got a drug interaction that could increase the levels of that medication. Somebody who's in liver failure, alcohol use, and myocardial ischemia. So that's like not enough blood flow to the muscle tissue of the heart. These are all things that we can make better, um, and hopefully lower that risk of the QT prolongation. And then there's some medications that there's a lot of medications, and I've got a couple of slides on that. So the general categories are meds that are antiarrhythmics. So meds that correct your irregular heart rates can affect this. A lot of antibiotics, a lot of the antidepressants and antipsychotics, aka why I'm talking about it, right? Methadone. Uh, Methadone has a black box warning. I believe methadone has 10 black box warnings, and I think I can't think of another med that has more. But one of its black box warnings is that it can prolong your QT. So let's go through these meds in more detail. So I'm I'm going to provide a list of the meds that I have in the highest, medium, and lowest risk categories on the website so that you can get them, because I don't want to just list them all off. I'm going to list the categories, and the ones that are psychiatric meds, I'll list them individually. So in the highest risk category, so highest risk of prolonging QTC, the antiarrhythmics, antibiotics, and some of the antidepressants. And so this is the tricyclics and the tetracyclics, and citalopram, uh, antipsychotics. And these are mostly first generations: perfenazine, chlorpromazine, mesoridazine, um, thioridazine, pimozide, and then the one second generation, ziprasidone, geodon. And so those other ones, maybe you'll see or use perfenazine, prolixin, or chlorpromazine, thorazine, but the other ones are not really used anymore. Some antivirals, specifically ones that are medications that are used for Hep C and HIV, and then cisapride. I don't think that medication, it's a GI motility medication. Don't think it's really used anymore. Believe it was taken off the market. But the thing is, when brands go off the market, generics don't. So that's something important to know. So those are our high risk medications. What are our moderate risk? So the ADHD medications, so your amphetamines, and that includes the street, like methamphetamine would be in that list. Cocaine would be in that list. So a lot of your like street drugs. And actually, one of the patients that I saw that went into Torsades, for one, his QT was 600, and I think 4. It was over 600. I've never seen I've seen over 500. I've never seen over I mean, over 500 is not super uncommon. It's not, it's certainly not good, but over 600, that was pretty incredible to see a QT over 600. And he was a homeless man, and I think he used meth, cocaine. He was on some of these medications prescribed, and then he was like belligerent and pulling his lines out and stuff. And they gave him IV Haldol, and then he went into Torsades. But he did not pass away. So the ADHD meds, so your amphetamines, atomoxetine, methylphenidate, Adderall, um, and then some other antiarrhythmics. So there's some antiarrhythmics that are in the high risk category and some are in the moderate risk category. So you have to look at the list to see which ones. And then antibiotics, like I said, there's antibiotics in the high risk and there's antibiotics in the moderate risk. Anticonvulsants, antineoplastics, that's cancer chemotherapy medications. And then remember the tricyclics and citalopram were in the high risk for antidepressants. So all of the other SSRIs, selective serotonin reuptake inhibitors, except citalopram, are actually in the moderate. And I think we don't think about this. I think everyone thinks about citalopram, and they don't think about all the other medications are actually moderate risk. Now, when this comes into play is when you've got somebody on multiple medications that can prolong QT, and you've got several meds that are moderate risk, and then the combination of that is high risk. So you could add fluoxetine to somebody who's on a whole bunch of stuff or has underlying issues that make them at risk for this, and then you push them over the edge with a fluoxetine rather than a citalopram because you didn't really think about it. And this is why this lecture is so important, is I don't want you to just think citalopram. For test's sake, it's probably just going to be citalopram, but in real life it could be any of them. So all the SSRIs, venlafaxine, gepirone, trazodone, nefazodone, um, hydroxyzine we often use. It's FDA approved for anxiety. It's a histamine blocker. It's a moderate risk for QT prolongation. And then you've got some meds that we use for high blood pressure, like beta blockers and calcium channel blockers. Got anti-nausea medications. So these are the 5-HT3 blockers, like Zofran, um, and then antipsychotics. So we mentioned what antipsychotics were in the high risk. There's some of them the the moderate risk. So haloperidol and clozapine are there. And as I said, IV Haldol is actually and I've actually heard conflicting evidence on this. I'd always heard that IV haloperidol was a higher risk for QT prolongation than oral or IM. But recently I had heard a talk on it actually not being a difference. But I think where there definitely is a difference with the IV is that IV haloperidol is more potent. So if you give somebody the same dose of IV, it's like giving them double the dose of the oral of the IM. And so that may be what the issue is. Somebody is giving IV haloperidol and they're giving them the dose that they would give them IM. And so that, because it's a moderate risk of QT prolongation, you're actually doubling the dose. You should give them a lower dose if you give them IV. Then that's what pushes them over the edge. And then appetite suppressants, phentermine, I don't really think of that as doing that. Fenfluramine, it's been taken off the market for everything except one type of seizure disorder. Lithium, we're still in the moderate risk, so lithium's in there. Alpha-zocin, that's an alpha blocker used for enlarged prostate. Some of the bronchodilating medications that are used for COPD, asthma. Phenylephrine is in this list, which is a medication that basically we're being told not to use anymore for cough and cold symptoms, and I never was a favor of using it because it doesn't work. Pseudoephedrine, because those are both amphetamine derivatives, and so kind of they're in that same category. Indapamide, octreotide, vardenafil, an erection medication similar to Viagra. Cimetidine, upset stomach medication, tacrolimus. I believe that's used for cancers. Tizanidine, it's a muscle relaxant. Methadone, amantadine, we use that in Alzheimer's and some other things. In EPS, we'll use that sometimes. Chloral hydrates, a sedative, might be used during surgery, and cocaine. So, and then in the low risk, I just went ahead and put quetiapine and risperidone because they have a low risk, as most of the antipsychotics have risk. I'm actually going to show those in another slide here in a second. So this next topic is what's some guidance when combining? Because I think that's, especially if you're a psychiatrist, you're thinking, oh, this person's on this medication, or I've got them on this medication, and then I'm going to add another medication, and they both, are QT prolongating medications. Can I do this? And most commonly, I see it with adding trazodone to an SSRI. And you don't need to be worried about trazodone with an SSRI. Everything that I have found, and I've done this a million times, this is just not something that you need to be concerned about. If you have a healthy adult, right? We're talking about a healthy adult, they don't have any of these like risk factors. You don't need to check their EKG or anything if you're adding trazodone to an SSRI, because that is just something we do so commonly, and it's just not an issue. Now, if they've got some risk factors, then I would do more. But you've got healthy adult, don't be worried about it. If they're on other meds in addition to those, then if they're on 3 meds, then that's when you start to think about it. But if it's just the 2, then I wouldn't. If somebody is over 60, it's probably a good idea to get an EKG screening before and after. Um, and then this next piece is going to be like, when, what do we do about the combining, right? So if they're over 60 and we're combining, probably should get an EKG. And then the next one is, there's three more factors. So they're taking other QTc prolongating medications. 2, they have they have a long QT syndrome. And 3, their advanced age of concern, like they're an unhealthy older person. So these are things, and when we're combining the meds. And then what do we do if one of those 3 things is positive? So if one of those, they're taking multiple QTc prolongating medications, they have a pre-existing long QT, their advanced age, and now we're going to add another med. What do we do? So let's see if they already have an EKG. And then if this is the 3rd med that we're adding, we need to do a full risk benefit evaluation, and might want to consider stopping one of the 3. And if not, get an EKG and routinely monitor their EKG. Right. So this is someone who they've got one of those 3 risk factors. They have long QT, they're older, they're on multiple medications. We're adding a 3rd med. We want to see about not doing this if at all possible. Like, could we pick a different medication to treat this disorder? Could we stop one of the other medications they're taking or change it to something else? And if not, let's carefully follow their EKGs. If you have a doubt about their cardiac status, by all means, consult cardiology. Ask them to say, I actually had a patient that had a bicuspid aortic valve. So normally your aorta has 3 valves. So those are the little cusps that are underneath the blood vessel that allow blood to go only one direction. They open when blood's flowing one way, and then they slam shut. Um, and typically you have 3 cusps, 3 little cups that suck together, but there's a condition where you can have 2. And this was something that was found routinely while, he was getting worked up for something else. And I think I was like adding, he was on, I know what we were doing. He was on escitalopram 20, and I was looking at pushing it to 30, which is over the max FDA recommended dose. And I thought, maybe because of this bicuspid aortic valve, that this isn't a good idea. And so I consulted with cardiology, and they okayed it. And then we went forward with it. And he did better with the 30. And so That was a case where I had him on a medication that could affect his QT, and then I'm going over the max dose, and we've got this cardiac condition that I don't know, if this is something that I need to be worried about or not with, making the QT worse. And so, and I got EKGs. And so I got the EKGs and I talked to cardiology and it was okay. And we went forward with it. So, you can always consult cardiology if you like feel like the patient really needs to be on a particular medication, but you're concerned about this particular issue. So in the case of we've got the QTc over 500, in this case, remember we're trying to keep it below the was it 450s and 60s depending on male or female, but for if we're over 500 milliseconds, we really need to stop these medications and talk to cardiology because we've got the EKG and now it's over 500. So let's at all stop whatever QT prolongating medication you can and talk to cardiology like fast because this person's at high risk of torsades once they get over 500. So what if we're over 475? So we're still over the limit that we want, but we're not up to 500. So in this case, we should stop one or don't increase any further and get another EKG in 1 to 2 weeks. Okay, we don't if we're not over 500, we don't need to call cardiology. By all means, if you feel like you need to call cardiology, consult cardiology. But for between the 475 and 500, we should just stop the agent and check it a couple weeks later. All right, when do we get an EKG? Right, electrocardiogram. You can call it's called ECG, EKG, and some of you may be wondering why is it sometimes an ECG and sometimes an EKG. Well, K is the German word for cardiac. They use a K, and so I talked about it at the beginning. Einthoven, I think he was German, right? So he actually is the one that came up with it, and so the Germans invented the EKG, so that's why it's called an EKG. But when we translate it into English, we use the English letter C, and so then sometimes you see the C, sometimes you see the K, and that's where that is kind of coming from. And so you may be wondering, I don't want to have to get an EKG on like all my patients, right? Like that's really burdensome. So who do we get it on? Who do we not get it on? Well, I've got a nice little list here for you. So this is when you should order it. If they're taking IV haloperidol or IV pimozide, or really any IV antipsychotic, I would get an EKG before and after just to make sure we're not prolonging that QT. So if you have to give somebody IV haloperidol in the hospital to calm them down, that's okay, but make sure you measure their EKG because we don't want them to get a long QT. Okay. Methadone, remember that's got the black box warning. So uh, lower doses of methadone, we don't have to get the AKG, but if we're at 120 milligrams or more per day, you should be monitoring with an EKG. That is a pretty high dose of methadone. And so we definitely need to be looking at, you might want to consider it at lower doses as well. I mean, you're going to take any other factors into consideration. There are other risk factors, but over 120 would be like a hard yes, get the EKG. And then the next one is say the patient's on an antipsychotic or a tricyclic or lithium or methadone or citalopram or a stimulant, right? One of the medications that I listed that was in the high and moderate risk for QT prolongation. So they're on one of those. Well, we don't need to get it if they're just on one of those medications, right? Unless the methadone was over the certain dose, right? Or the IV, right? They're just on the standard of one of those meds. So if they're taking one of those meds and they have one of the following conditions that I'm going to list, then you get an EKG. So one of those meds plus bradycardia, slow heart rate, or structural heart disease. And so that was my patient with the bicuspid valve. To me, that's I'm not a cardiologist, but that sounds like a structural heart disease to me. I don't know if a cardiologist would consider it that. So I got the EKG. But any kind of, I would get their cardiac history. Do they have a history of cardiac arrhythmias? Have they had prolonged QTc in the past? Do they have long QT syndrome? Do they have hepatic dysfunction? which could cause those medications levels to go higher in the blood, right? So I think I'm giving them this dose, but it's actually more. They have a history of syncope, which is fainting, a family history of, and that's we're thinking that that's like a cardiac cause, right? So they have a family history of sudden unexplained deaths, family history of congenital long QT. They're on other QT prolongating drugs, so they're on those plus one of the other ones. They're on a P450 inhibitor that affects those drugs, or they have a risk of electrolyte abnormalities, right? If we have the low potassium or low magnesium, or they're taking a diuretic or something like that that can cause that, or they're taking a blood medication that can lower their potassium, or they have an eating disorder, specifically, anorexia and bulimia, both they can affect your electrolytes. So if they have electrolyte disturbance and they're taking one of those medications, they're at risk of long QT. Or if they have low potassium, magnesium, or calcium, right? And so any of those conditions plus one of those meds, get the EKG before and after and if you're going to change the dose or you're going to change, to the med, let's find out what their baseline is and let's find out what it is afterwards. And then one more is if there's a concern for acute ingestion. So we're worried that they overdosed either intentionally or unintentionally on one of these medications that could, and just in general, if someone's had acute ingestion of any kind of medication, you're going to want to get an EKG. If they have acute cardiac symptoms, of course, we're getting an EKG. If they have altered mental status, we're ruling out causes of delirium. If they have delirium, those are more medical issues down there. It's things that psychiatry is probably not going to be concerned about. But for completeness, I've added it. But I think that you'll all find that very helpful to when do I get the EKG? It's well, if it's on one of those meds and they have one of those conditions. So, and then next, you've got the EKG. Now what? Right? We got it. Okay. What do we do with it? I don't know what to do with it. I got it, but now what do I do? Well, I've got a nice little chart here that kind of it's like a little algorithm, right? So we got it, and is the QT for men over 440 or over 460 for women? If no, then go ahead and continue the therapy and repeat the EKGs annually or with dose changes. If yes, it is above that, well, let's check their potassium, magnesium, and calcium. Okay. Are those low? If yes, correct it, right? Give them magnesium, calcium, or potassium. Correct the electrolyte disturbance. If we checked it and it's not low, now what? Could this be caused by a medication, right? If there's no medication that they're taking that could cause the QT prolongation, then they probably have long QT syndrome. Consider that. Send them to cardiology. See, for that to get, diagnosed or worked up for that. If yes, we think it's medication induced, then we ask a series of other questions. Is the QT over 500 milliseconds, or did it increase more than 60 above their baseline? That's question one. Question two, do they have one of the high risk features that I mentioned before? And three, do they have syncope? Did they pass out? So if the answer is no to all three of those questions, then you could consider changing the medication, right? Because we've already kind of determined that it is medication induced, but it's not their QT is not above 500. They don't have high risk features. It hasn't been a more than 600 change from baseline. They didn't have syncope. Um, if you really need to continue the med, continue it and monitor them. Otherwise, just change the med. Okay. But if we've determined that it was caused by the medication and they did have, a greater than 60 millisecond change or over 500 or high risk factors or syncope, then admit them to the hospital. Admit them to the hospital, discontinue or reduce the med, put them on continuous telemetry, and treat the arrhythmia if they have one. So hopefully that helps all of, us psychiatrists and non, cardiac inclined patients or doctors, and to understand when to get the EKG and what to do with it once you've gotten it, and what those high risk factors are, what those medications that are at risk, and fills all that in for us. So on the next slide, I actually have a list of all the psych medications that can prolong QT and what is their expected amount of milliseconds that we could get. So I've kind of rank ordered these by which ones typically increase it the most to the least. Okay, so trimipramine. So most of the big first lot of these are TCAs. So trimipramine, not used that often, 18.6. It's the highest risk of the antidepressants. Clomipramine, close second at 18.4. Meprodaline, something that we don't have in the United States, 13.9. Doxepin, 12.8. And now we do frequently use doxepin for sleep, but at very low doses. So I'm not sure if if this is a dose dependent response, but doxepin is a higher risk. And then citalopram, right, the one that we're going to be talking about with the upcoming lectures, 12.8. And that's why the warning is on citalopram. Interestingly, that I think people don't think about it with the tricyclics that as much. It's always, you're always thinking citalopram, but trimipramine, clomipramine, meprodaline, doxepin, all worse, right? And mipramine, 11.8, amitriptyline, 11.6. And remember, more than 10 is concerning. So these are the change from baseline, the increase, the average. This is the average increase. Some people are going to have more. Some people are going to have less. Some people aren't going to have a change at all. This is just averages. And I looked at several papers to get these numbers, and there were different numbers on different papers. And so I just tried to get an average number, but these are not like hard and fast. Okay, so next, decipramine, 11.4, nortriptyline, 10.9, venlafaxine, 10.6. And we don't see the warning on venlafaxine, but 10.6 compared to 12.8 for citalopram on average, not that big of a difference. And that's why I said that a lot of these antidepressants, I think citalopram gets demonized because it's the highest on the list, but there are several antidepressants on this list. Next, mirtazapine, 8.1, fluoxetine, 4.5, bupropion, 3.6, escitalopram, 2.7. And I think that's interesting because escitalopram is the S enantiomer of citalopram. It's half of citalopram. And so, and in my patient, I was increasing his escitalopram, and I was a resident at the time. I didn't. I was like, why isn't escitalopram, Lexapro having the warning? Well, apparently this is why. The average increase in QT is only 2.7 milliseconds compared to 12.8, and so there's just not the risk with escitalopram. So sertraline 1.7, paroxetine 1.7, fluvoxamine 1.7, and then this next one is interesting: trazodone minus 12.1. So it actually decreases it on average. And remember how I said, combining trazodone is not that big of a deal in a healthy patient. And interestingly, trazodone is still listed as a moderate risk to increase it. But on average, people actually have lower QTs when they take trazodone. And then vilazodone, vortioxetine, and duloxetine were all noted to have no effect on QT. And these are the kind of things that I think are interesting. I think when people are out there practicing, they just kind of pick the same med over and over and over for patients. But there's actually reasons to pick one med over another. There are different risks. If you have somebody with some heart issues, maybe you don't want to reach for citalopram. Maybe you don't even want to reach for a mirtazapine or a fluoxetine. Maybe you want to go even lower risk. Maybe you want to give them a duloxetine, right? That has no effect on QT. And see, these are the kinds of things that I'm hoping that listening to this podcast series is going to help with. Is you're going to understand all the risk factors. These meds are not the same. As you can see here, this is just one aspect. We're just talking about QT. And if you look at the SSRIs, they all prolong QT on average a different amount. So they're all different. And so, like I said, this is just one, and we're going to go through them and talk about all their differences, but there are minute differences in all these different aspects with all these different medications, and you have to take these into consideration if you want to give the patient the most effective and the lowest risk treatment. And that's what we want to do. We want to give somebody the medication that's the most likely to work with the least likely to cause ill effects. And this is just another thing that you have to kind of take into consideration. And that's why I'm dedicating an entire episode to this. And I think that QT is something that most of us probably don't think of that often, but it's actually super, super important. Okay. And so those are the antidepressants. This next slide, I went ahead and just, I'm going to talk about when we go through the antipsychotics, I'm going to go through this list again. But since we're talking about QT in general, and we've talked about antipsychotics, I want to mention antipsychotics as well. And also, I think it's important when you're like kind of comparing these to the antidepressants, you can kind of see the differences. So number one on the list, mesoridazine, 39 to 53. Holy freaking crap. That is a lot. I mean, there's a reason you've never heard of this med, and it doesn't exist anymore. I put it in here just to illustrate that we once had an antipsychotic that prolonged QT by 53 milliseconds. And then, as the name implies, mesoridazine, thioridazine, they're similar meds. Thioridazine's next, 33 to 41. These meds actually have black box warnings for QT prolongation. No other psych meds do. Methadone does, and then mesoridazine and thioridazine. And I know most of you are probably saying, I've never heard of thioridazine. It's Mellaril. And maybe most of you are not. Most of you that are my age or younger. But the older folks, you guys remember Mellaril. And I'm actually old enough to have seen it. And I was in med school, and in Texas, the state prison hospital was in my medical school. And I had a patient that was on Mellaril, thioridazine. And it also, in addition to QT prolongation, causes pretty significant orthostatic hypotension. And so we were being consulted because he was getting he was on the infectious disease service, and he was taking an antibiotic that was lowering his blood pressure. And they're like, well, we can't give him this antipsychotic. And so he had schizophrenia. And so we had to try and find something else to help him with. And so that's my one experience with seeing a patient on Mellaril. And then I learned that, it's one of the big QTc prolongators. And, people think that our prisoners get free healthcare, but it is really, really bad healthcare. Like I I worked, like I said, the state prison hospital was in my medical school, and the stuff I saw, you would not want to get medical care in prison. You're better off not having insurance and going to the ER and being able to actually see a doctor, even if you don't have health insurance, than getting it in the prisons. And I'm sure there is good care that happens there. I don't want to talk ill of those of you that practice in the prison, but I think even those of you that are doing it well, know that the care there is not good, for a variety of reasons. But anyway, this patient he was actually on Thorazine and Mellaril, which is an insane combination. He's on two medications for the exact same condition that have like the exact same side effect profiles. Insanity. But anyway, next, Pimozide 19, chlorpromazine, that's Thorazine 19. And so all those are all worse than every other antidepressant. Okay. And we still do use chlorpromazine, Thorazine. We still do use that one. I've saw that a lot more than the thioridazine. I saw the one time. Next, clozapine 10, ziprasidone 9.7, allopurinol 6.93, acinapine 5.6, risperidone 4.77, olanzapine 4.29, quetiapine 3.43, haloperidol at a 1.69, though questionable. Is it worse with IV or not? Paliperidone 1.21, and then we actually have aripiprazole minus 0.43, cariprazine minus 1.45, brexpiprazole minus 1.46, lorazepam minus 2.21, and I don't know, I have duloxetine on there again. I take that off. And then with a closing, I just want to talk about citalopram since that's what we're about to talk about. So let's go into more detail on citalopram and QT prolongation because that was kind of the whole reason why we're having this episode at this point in time. So the it's dose dependent. So that means the higher the dose of the citalopram, the longer that milliseconds of that QT prolongation. So that's important to know because if it wasn't dose dependent, we'd probably want to. That would mean that even at low doses, it could cause it, right? But we're basically saying at higher and higher doses, it's more and more likely to cause it. And so the max dose used to be 60 milligrams a day. That was lowered to 40. So the current max dose of citalopram is 40 milligrams a day. And also, and whenever this report came out that it could cause this problem, they lowered it to 40. And then they said, but for patients that have hepatic impairment over 60, 2C19 poor metabolizers. So 2C19 is the enzyme that breaks down citalopram. If you're a poor metabolizer at that enzyme, um, or you're on a 2C19 inhibitor, or if, and for whatever reason, they said if you're taking cimetidine, cimetidine is actually a 2C19 inhibitor. It's one of the few. And so that's why it's mentioned. It inhibits, cimetidine is a crappy med that inhibits like everything. And it's like almost never used anymore. It's a H2 blocker, um, GERD, acid reflux medication. But for those patients, 20 milligrams is the max. So hepatic impairment over 60, 2C19 poor metabolizers, and taking cimetidine, 20 milligrams the max. Otherwise 40, no longer 60. And then we're saying to use caution. So we've got citalopram. So in patients taking citalopram, we want to take caution in patients that have congestive heart failure, bradyarrhythmias, slow heart rate, are predisposed to hypokalemia or hypomagnesemia because of an illness that they have. So they're more likely to get low potassium or magnesium because of an illness they have or a medication they're taking, like diuretics. Those I think diuretics when I think about that. Um, we want to avoid it if they've already got a long QT syndrome. We want to avoid it if they're taking a 2C19 inhibitor. And so not just cimetidine, but omeprazole and esomeprazole. So that's Nexium and Prilosec. So the max is 20 milligrams if they're taking cimetidine, because cimetidine is a potent 2C19 inhibitor. Omeprazole and esomeprazole aren't quite as potent. And so the warning that you can't give them more than 20 isn't there, but I would still consider it. I mean, honestly, I wouldn't give them citalopram if they were taking omeprazole or esomeprazole. In fact, honestly, I rarely give this medication at all because I don't really see that it has much benefit over escitalopram, Lexapro. Before Lexapro was off patent and it was expensive, we used citalopram a lot more. But since it came off patent, I don't see a lot of psychiatrists giving citalopram, Celexa. I see PCM still doing it, and I would just say there's. I guess if you've been on it for a really long time, we don't want to rock the boat and change your meds, but there aren't really any good reasons to start a patient on citalopram, Celexa. There just aren't. You've got so many other choices, and you've got S-citalopram, which is like virtually the same med without all the downsides. Now, there is a little bit difference, and we'll go into that when we get to these medications in detail, but there's really not much difference. And so, if I have the choice of giving them a med that could cause more likely to cause sexual side effects more likely to prolong their QT by 12.8 milliseconds versus what was it 2.7 milliseconds with escitalopram, why would I go with citalopram? I just wouldn't. And if escitalopram didn't work, why would I give them citalopram? It's virtually the same med. I would give them a different med. And so, and the thing is, we're saying don't take this med with Prilosec and Nexium, like have caution. Do I want to have caution? I don't know if this patient has long QT syndrome. I don't, if they're going to buy Prilosec off the shelf at some point and just take it. I don't know if they're just going to get low potassium for some reason, or someone's going to start a diuretic on them, like, so any of this stuff could happen. And then they get a long QT, and it's because they were taking the citalopram, you know, so why even give it to them at all? Like, this risk is not massive. I want to make that clear. Like, the risk of citalopram causing torsade de point, there's only a handful of cases that have actually got to that point. There are definite cases where QT has gone over 500. That has happened. That happens not super infrequently, but torsades, that there's just a handful out there that have happened. So the risk of what we're really worried about with citalopram is, I want to make that clear, that the risk of torsades is still quite low. But if I can lower that risk even further by giving them a med that's virtually the same med without that massive risk, why not do that? Right? Why not just, I mean, there's reasons why I don't want to give someone Prozac, fluoxetine, because it interacts with a crap load of medications. So why not give them something that's not going to do that? I don't know what med they're going to be started on in the future, and if someone's going to realize that Prozac interacted with that med, why deal with that situation? I mean, there are reasons why I would use it, but there are very few, if any, reasons why I would give someone citalopram, despite the fact that the risk of them getting torsades is super low. There's just so many other options, and a citalopram is the best one if you're going to give them something that's similar, right? But if you were, you want to, you're going to probably want to get their labs. So if they have a low potassium or magnesium, you want to make sure that's fixed before starting them. I mean, this is actually the guidance that's out there. It says correct their low potassium and their low magnesium before you start citalopram. Why would I do that? I mean, I would correct it because it needs to be, but why would I give them citalopram? This person's like at risk of it going down again. And I'm going to give them a med that could like combine with that problem? No, just don't use it at all. Right? The guidance says correct it, then use it, but don't use it. Use something else. Okay. What else? We got increasing. You're going to want to increase their EKG monitoring. So if they're on citalopram and they have congestive heart failure, bradyarrhythmias, they're on other medications that prolong QT. So basically, if they're having all these risks, I mean, I guess if you had a patient that citalopram was the only med that ever worked for them, and like I said, I would never start it. Like, I would never go down that road. Now that we know this information, I would never like put them on it. I would use a different med first. But this is someone who's been on it a long time, or they tried a lot of other medications. They tried escitalopram, and citalopram's the only one that worked. But then they've got these other issues. Well, you need to correct their potassium, you need to correct their magnesium, and if they have these heart issues, you need to monitor their EKGs more frequently, right? And so that's where I could really see this coming into play. This is a patient that they either had tried everything else and they were on this and it's the only thing that worked, or maybe they took this in the past and then we tried other things and nothing worked, and they kept saying, when I took that Celexa, it really worked well. I'm like, well, dang it, nothing else is working. Let's go back on the Celexa. And if we have one of these other issues, we'll just have to deal with it. We'll just have to order the EKG. We'll have to like make sure they know not to take Prilosec or Nexium. Like, there are other medications they can use for upset stomach that don't inhibit 2C19. But like I said, I want to get this information out there. This is not to say, never to use this med. It's, if you're going to use it, you need to be aware of all this stuff. Okay. So if they have mild or moderate renal impairment, we don't need to adjust the dose, but for severe, we do. And then educate the patient on signs and symptoms of an abnormal heart rate or rhythm while taking the citalopram. And then escitalopram's lower risk and there's no adjustment warning. Let's just use that. Okay. And so that takes me to the end of QTC. I hope, those of you out there that didn't know that much about it, or you'd heard about the warning for citalopram, or you'd heard about it maybe from some antipsychotics, maybe you'd seen it out there, but you didn't know that much about it, that you understand things better now, you feel better prepared to go forward with, if we've got to combine things, if we've got to use certain meds, you know, I don't want you to just feel like you don't know what you're doing and you're doing it anyway. That's what we want to avoid. I want you to understand the QT, and when we need to take the risk, that we know how to take the risk. And when we can avoid taking the risk, we avoid the risk. And then that we are just aware that maybe these meds you didn't think about um, can cause it. And I know the TCAs I mentioned, but normally when we're using TCAs, we're using them at very low doses, but not always. And sometimes I'll start people on low doses of TCAs and we'll end up increasing it, and it ends up becoming their antidepressant at some point when that was never the intent. I was giving it to them for sleep or pain or whatever, and it ends up getting to an antidepressant dose. Well, when I was giving them 10 milligrams, maybe I didn't need to worry so much about the QT prolongation, but now that they're taking 50 to 100, maybe I do need to worry about it now, and I need to worry about all these other factors and these risk factors and these other meds that they're taking. Maybe I do need to get an EKG, right? And so, I mean, it's complicated. And like, if you're a patient out there and you feel like, oh my gosh, I am taking a bunch of these medications, I wonder if my doctor is aware of this, because they may not be aware. They may not know, because you might be taking some of these medications. Maybe you're like, oh my gosh, I'm on Selexin. I buy Prilosec on my own, and I never told my doctor that I take the Prilosec. Maybe you need a lower dose. Maybe you're like, hey, ever since I took that Prilosec, I feel funny, because I'm getting higher levels of this med. And so it's hard to be perfect. Yeah. And not just hard, it's impossible. No one can be perfect. No one can have all this information in their head and make the best decisions all the time. That's why I think it's helpful for patients to have as much information. It can confuse, but it can also, like, I can't tell you how many times a patient has brought something up that I may not have picked up on my own had they not mentioned it. A lot of the time they bring things up and you're like, no, no, I'm not concerned about that. And you educate them and they feel better. And sometimes you're like, oh my gosh, I'm glad you told me that, because that's actually really important. I had a patient I was given naltrexone to for weight loss, and he had a surgery and he was going to get the opiates. And it's like, thankfully you bring that up. It's like, hey, that's going to make those opiates not work and you're going to be in a lot of pain. And so you may not know, you're not going to get a full history every time you see somebody. And so that's why it's great if patients know as much as possible and they ask these questions. And because it makes them feel better that they got that information, that makes them feel like, okay, the doctor understood it, they explained it, I feel better about it, great. Or, oh, I'm glad I brought that up because it was something that maybe that they didn't notice, or they didn't see in my medical record, or they didn't think of, because like, I can't think of everything. And if you help me by bringing things up, it can be very helpful. Like, I don't find it annoying that patients ask questions at all. I want you to ask questions. I want you to feel, because I don't want you to like not know what the heck's going on and then go home and never take the med. Or, you go home and you read something, you're like, oh, I read this thing, so I'm not taking this. No, call me. Because I do that. Call me, call the office, leave me a message, say, hey, I went home and then I found out this stuff and now I don't want to take the med. Well, maybe that's not a problem, and I need to talk to you about it. Or maybe it is, and that's something we just didn't talk about in our appointment, and I'm glad you found that, and maybe I can give you a different med that won't have that same problem, and we don't have to wait till a month for our follow-up appointment to address the concern. We address it, 3 days later, when you like made the decision to stop taking the med for one reason or another, and then I could prescribe you something else. And then when we follow up, you've been on a different med, right? And so that's why I think it's great, for everyone to kind of know as much as possible so that we can provide the best care to everyone. And so hopefully you guys like this lecture about QTC, follow, like, rate it, keep listening, tell your friends, I hope, give me feedback. I hope you really like the podcast, and I'll see you next time.